So we assembled a little panel of endoscopy folks that you can ask your questions of. So, question in the back. Yes. Yeah, so the question, correct me if I'm wrong, is your question is, when is it best to let them, how important is it that they use only the left hand, and at what point do they learn that, as opposed to using both hands? Oh, if you push the button, you can turn
that
the
button. Okay, I think yeah, it's important. I tell them right off that the left thumb is on the big dial and never leaves the big dial. You never cross it over to use the small dial because you lose control of the big dial. And if they do that, I bend their thumb back.
Other questions?
Disagree with that, actually. It's really hard for me because it's hard for me to disagree with Jerry, but I was actually trained at a different institution where I was slapped if I did that, actually, Jerry. This is trained by Mark Pacheco at Cornell, and I got a good shove in the shoulder whenever I sort of went like that, and actually he was a big proponent of using the left hand to reach over to the small dial and saving the right hand just for torquing with the screen. Pushing and controlling with the scope and also using
That goes to show how wrong some people can be. But let me tell you that there are lots of ways to do colonoscopy, and what I mentioned to you is one way of doing it, but there are lots of different ways of doing colonoscopy. In fact, some places I go to in different countries, they do two-person colonoscopy. One does the shaft, and the other holds the dial. And it's quite incredible. They can even get through the colon. That's what happens.
That's sort of the beauty of it, is that the fellows get exposed to all these different ways, and then they adapt those techniques that work for them into their own style.
Any tips about that? Like if you have fellows who just have smaller hands, what do you tell them?
Go into liver. No, I think everyone's point's well taken. I mean, I don't think it's wrong to, I don't like locking the dials on insertion because I think there's more chance, especially with a novice, to perforate. But I think it's important to lock the dials for manipulating. And I think there's probably everybody in the room who's been doing this for a long time probably unconsciously uses their thumb to move both dials when they're trying to get a polyp in position or something like that. But I think when they're starting in the beginning, I think you just have to keep it as simple as possible. But I think, like Dave said, just to expose them to all the different ways. And, everyone's, there are people who aren't as strong. Sometimes you see some fellows really using all their muscle to push that scope in, but I think you just adapt it to what each individual's skill level and body sizes.
It actually took the CRE infection thing to get that published this month in Endoscopy as a breakdown of the tip of the scope. It's scary what's inside it. Can I just say one general thing? What we're all describing here is an art, which is why it's tough. I mean, everything we talked about is completely non-science, right? And I think that's the beauty of what we do, and that's how you know it when you see it, and you know it when it's bad, and you know when it's good. It's because it's an art form. And I've thought this ever since I've started endoscopy, and I know when I watch Jerry, for instance, it's a beauty to behold. And you watch some of the best Japanese endoscopists, and it's a great phenomenon, and yet it's very hard to describe. And how you hold the scope, and whether it's like this, and whether your hand's small, whether your hand's large, and how many hands you use. I think these things evolve, and each person is different. We have a method that you've heard that most of us follow, and maybe there are variations from different people. I don't think that matters too much, as long as you're not doing anything bad and harming the patient, and you're achieving the goal. But these things of holding the scope, I don't think this is working, of holding the scope with, can you hear me? No. Maybe this one. Oh, it's reversed. Holding the scope with one hand only and not doing anything with the right hand up here, I don't think that's a hard and fast rule. If you're an ERCPist, like some of us, you very rarely use the right hand on the control because it's doing something else. And I don't think these things matter as long as you're achieving the goal. And so if you think back to when you started driving a car, you didn't do one thing at a time. Well, maybe you did the first time you did anything, but you learn a sequence of moves that got you from A to B sort of safely. And then you learned how to embellish that, and you got better at it. Maybe you didn't become a race car driver, but you did it competently. And I think that's very much what we do when we teach endoscopy. It's an art form that's very hard to describe, so we break it up into pieces that allow us to say, you know, you do this first and this first because this is what happens. But in the end, it's the very last stage. It's your unconscious competence. Did you do something with all the things that we do? And we've measured the vectors that you change, and certainly in ERCP, it's about 12 things that you do at the same time to achieve a goal. And I think the danger, I think, is splitting it all up into pieces. And I've never liked to do that. Chris can tell me if I'm wrong, because I try to teach him. You learn a lot of things all at the same time, which allows you to get from A to B and achieve a goal. And I think that's much more important than saying, do this first, this second, this third, this fourth. And I think that sort of spoils the ecstasy of getting something. You know what the fellows are like when they achieve something. They got through the pylorus for the first time. They thought that was fantastic. And then 3 months later, they've forgotten all that because they're doing something else. So that, I think those aspects of teaching endoscopy and enjoying it are just as important as breaking it up into little pieces.
I'd like to get the panel's opinion about one question, which is when you get stuck and you see them get stuck and then you take the scope to get them unstuck, what tips do you have to deal with that moment so that it's not just you getting them unstuck and then giving the scope back? Like what techniques have you tried or what have you done that allows you to make that a teachable moment as opposed to just moving on and getting through the procedure?
I think it's helpful that, as someone mentioned before, having an ongoing dialogue or monologue, as you put it, from the teacher. I think sometimes it's useful to let the apprentice do the monologue and say, what are you seeing? What are you thinking? What are you up against? Give me a circle line tour of what you're seeing. And sometimes that technique will work. And it's not working, what other repertoire do you have? And I think a lot of the previous discussion is really introducing repertoire. I think every master endoscopist does it differently. It's what works. Some things work and some things don't. But you need to have a repertoire. And I think that with the students or with the fellows, you let them try. You say, hey, it's not working. Why is it not working? What else is in the repertoire? What else can we do? You talk about it.
Makes sense.
Exactly how much time you give them, I don't think there's hard and fast rules. You can sort of tell when they're getting frustrated. Mm-hmm. You can see that with their body language, and that's a good time to intervene before they flip out or something terrible happens. But I think there's no hard and fast rule of time.
Yeah, the other thing I'd like to say is just, and Jerry, I think, kind of mentioned it, is make sure that they're not afraid to pull back. What I'll often do is, if they're frustrated, is tell them simply to pull back, and pull back a lot, and then go back in. And they learn that things change as you go back several times.
Any other questions folks have for the panelists?
There's another word or instruction to learn that: stop.
Stop.
Just tell them to stop whatever they're doing when they just before they freak out, when they're sweating and they're worried, they don't know what's going on. Just say stop, and then figure out with them what went wrong, how they can correct it. Because they often don't do that. They don't stop what they're doing. They just keep repeating it. And then you're trying to correct something that has already gone, beyond a point of not almost no return, but stopping.
Bridget, I don't know if you're going to get to it, but I think we're woefully deficient in the beginning and the end of an endoscopy. I don't think that we're great at getting informed consent. Mm-hmm. I think we frequently don't witness it at all. It's all done by the time we start. I don't think we're there when they talk to the family or to the patient afterwards or the follow-up. I think those ends of it have been woefully ignored. Maybe we need a lecture from legal on the informed consent because that's such a major, probably at least as important as the documentation is the proper obtaining, and we don't do that.
Right. So I think Dr. Kotler and I are going to talk a little bit about sort of tips about how do you do those teaching in those kinds of moments, but I agree. I mean, we're talking in our fellowship during orientation period of actually having fellows be witnessed for a certain number of EGD and colonoscopy consents as part of their orientation period, so that we know that our faculty have seen them do it, and then we can trust them to do it on their own. And sort of breaking up those pieces in a little bit more real way. So we say, we've watched you do it, we trust you, now go do it. Completely agree with you. One thing that the few times when I have more of a senior fellow with me, I will ask, what is it that you want me to watch you do during this procedure? What do you need help with? Because I know that you're going to get to the end, but what is it that you want feedback on during these next 30 minutes that I'm with you? And then I know what I'm watching for, as opposed to just kind of hanging out and hoping that nothing bad happens.
I think it's also a simple thing just to set the expectation level up front. So, when dealing with a first-year fellow who, has had 30 colonoscopies or none, you can tell them, I don't expect you to complete this. If you do, great, and that's fantastic, and I think Jerry made a great point about being a cheerleader, but I think it's also to ease their mind a little bit and take that pressure off that, there's very low expectations here. For advanced endo, for something like ERCP, as David was saying, there's so many different technical maneuvers. For our curriculum, we've had to break it down into milestones. And, we always meet with our fellow every quarter and say, I know it's frustrating that you didn't get to do, the ampulectomy or whatever it is in your third week of fellowship, but you're not expected to learn that or to be proficient in that until the fourth quarter. For those first 3 months, again, there's all different ways. These are the things we're going to focus on and make sure you're proficient. And I think we can do the same thing with colonoscopy. And sometimes it's learning backwards. So as Jerry said, withdrawing is much easier than getting to the cecum. So I think telling them that up front is just a major pressure release for them, that they don't feel and also to say stop, to give them the permission to say, listen, if you don't feel comfortable, stop and tell me, rather than try to, tough your way through it and cause an adverse event.
Peter, and then Jim, and then we're going to move on.
I think it's very helpful also to emphasize how big a learning curve there is to doing endoscopy, and it's frequently helpful to tell them. I certainly, with my experience, when I finished my fellowship compared to how I was 5 years later, after X thousand more cases, there's a tremendous difference. You continue to learn. Mm-hmm. I don't think that fellows are as good as they're going to be, and we need to emphasize how long the learning curve is to really feel comfortable doing this.
I want to thank our panelists before we move on to the last part of our evening.